So let's start from today our hard work, and I have a great faith that we will get the maximum result as much as we working hard. My advice is for all of you, um, forget what happened in the past about any bad experience. All of us has good uh, good times and hard times. Uh, Keep the good times and the good results in your mind to motivate yourself and learn the lessons from the hard times. Anyone uh, anyone has before examined this exam to be consider the first time or the times before as a good trial and experience. In my opinion, to be exam is a very, very unique exam. It need very deep exam experience. Whatever your knowledge, you can't pass the exam without the some experience, either from seniors who pass this exam or from a trial that you didn't pass it. Both of them are a must now because this is the most important, the most difficult exam in radiology. So keep in mind all these points. It will help you. It will be the lighthouse for yourself because sometimes our hesitation and the fear from the past become a very big challenge and barrier against our progression. Anyway, let's start our first session for 2026 January group. Yes. Our candidate requests a control. This is 17-year-old male patient complaining of seizure. You can request control.
Yes, sir. I'm trying to,
No problem. I will,
but I'm unable to request for the control, sir.
no
Mm.
problem. Go on.
Okay. So I'm presented with the MRI T2 weighted actual sequences of a 17-year-old male. And I'm taking a minute through see through the images. Okay. So in the visualized actual sections, I can see that the both the lateral ventricles are widely spaced with absence of the septum pellucidum. Also, I can see that the chiral convolutions appear very small and closely spaced in these images. And these lateral ventricles also appear to be dilated and mildly prominent. Um, um, Sir, can you scroll a little down for me, sir, please? The occipital horns also appear to be prominent. Then, um, um, based on these images, I can see that there is absence of the corpus callosum along with the septum pellucidum, giving rise to colpocephaly that is widely spaced lateral ventricles, like a Viking king sign of appearance. And also, I can see that. Can I see the images in T1 axial also, sir? Okay. So on the T1 axial images, I'm trying to look for any other additional findings. Okay. I can see that there is a cystic encephalomalacia which is seen adjacent to the right lateral ventricle. And then I would like to look for the sagittal images so that I can evaluate the posterior fossa. Um, Okay, in the given sagittal images, as I mentioned previously, there appears to be absence of the corpus callosum. okay, with the multiple tiny gyri which appear to be closely spaced. I would like to look at the posterior fossa, and I'd like to see if there is any crowding of the posterior fossa or an inferior okay migration. So it is not there, so it appears to be normal. So I would like to consider the possibility of corpus callosal agenesis or colpocephaly associated with polymicrogyria, sir.
What else? Look here, please. What else?
With the corpus callosal lipoma.
Okay, no lipoma. What else? Look here. Concentrate in this section, please. What happened here?
Oh, okay. I can see that some amount of okay, the white matter is not clearly differentiated. The gray white matter differentiation is not that clearly maintained, and some amount of gyrations are also present adjacent to the ventricles.
So, what is this? What's your diagnosis?
So, it can be mm, it can be because of the neuromigrational disorder, so that is gray matter heterotopia.
Yes, yes.
Yes,
Which
sir.
type
It's gray
of
matter heterotopia.
heterotomy? Which type of heterotomy?
Uh, I'm not sure, sir.
How many types of heterotopia?
Mm, uh, 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 they can be band heterotopia, lissencephaly associated heterotopias, nodular
Yes,
heterotopias,
yes, yes. So
nodular
you
as well
have
as
two
diffuse
types,
heterotopias. Mm. Yes, sir. Nodular
nodular
as
or
well as
band.
diffuse.
Nodular
Mm.
or band.
This looks like double
Or
cortex, so
yes,
it will be like
double
band
cortex.
heterotropias. Mm.
Excellent. Okay. Uh, is it
Mm.
common in male or in female?
Uh, Band heterotropias. It is a X-linked chromosomal
Yes,
disorder,
yes.
X-linked
Common in
dominant
male or
disorder.
female?
Female,
Or in
female, sir.
female. Okay. Thank you, doctor, so much. Uh,
Yes.
it was a case of, look, my colleagues, double cortex sign. So it is band heterotopy, diffuse band heterotopy. And if we look here, the postfrontal horn of lateral ventricle are parallel, and there are a little bit colpocephaly. You didn't ask me for coronal. Coronal is very important. What is the meaning of this sign, doctor? What is the meaning of this sign?
It is a
Hello?
Viking horn sign, sir.
Yeah, excellent.
Racing car. Yes, sir.
No, 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 no. This is Viking helmet sign. How could
Viking horn.
you,
Okay.
which section you can see the racing car sign? In which section?
That is
What?
in axial only, sir.
Excellent in axial. Why Viking
Mm.
helmet sign? Because the third ventricle is elevated, and both
Elevated.
frontal horn are looks
PC.
like the pill horn sign. Overall, it is a
Hmm.
Viking helmet sign. This is due to corpus callosum agenesis. Okay,
Genesis. Mm.
okay.
Yes, sir.
Uh, Very important association. We should rule out any herniation of the tonsils or the vermis.
Mm.
So, because Kayari is highly associated with very common associated. Here, no Kayari. So, my colleague, it is very common case of epilepsy and mental retardation, especially in female, the double cortex sign, which is a band
Mm.
heterotopia. ماشي.
Mm.
Okay, sorry. What about uh, encephalomalacia? Somebody asked about
Yes.
this is encephalomalacia. This patient may have some sort of ischemia injury. We don't know the full history of this patient, but at least why I bring this case, because really what will take your eye first is the double cortex sign, and many of us may miss this racing car sign or may miss this is Viking helmet sign. and so he missed very important other pathology due to search satisfaction of search. Okay, so it was a case of search satisfaction, and it is very common mistake in Viva exam. Thank you, doctor, so much. By the way, it is
Yes, sir. Thank you.
common in female. Common in
Hmm.
female.
Yes.
Thank you so much.
Thank you, sir.
Uh, Next candidate.
Good morning, sir.
Assalamu alaikum, sir.
I missed my turn, I think.
No problem. Candidate one, if ready.
Yes, sir. Yes, sir. Yes, sir.
Okay, welcome.
Yes, sir. So, sir,
This
shall
is
I request control? So you will,
one second.
okay, sir.
This
Okay,
is
sir.
20. Request control, yes.
Okay. Sir, like if you could, uh, sir, I think,
20-year-old female patient complaining of progressive weakness and paralysis of the limb over the past week.
sir,
Yes.
I'm not able to control the film, sir. Like, if it is it possible? Okay, sir, thank you. So I'm provided with T2 sagittal MRI images of cervical-dorsal spine of a female, 20 years old female who is complaining of weakness. Immediately, I noticed that there is a large, hyper-intense signal seen involving most of the cervical cord. The cervical cord does not seem to be expanded. Rest of the visualized cervical vertebrae appear normal in height. Some desiccation changes are noted. In my routine practice, I would like to see the stir images as well to characterize this further. So here I'm provided with stir images which further re-demonstrate a presence of a large high altered signal intensity which is appearing hyper intense on stir and T2 weighted images involving almost whole of the cervical cord. The cervical cord does not seems to be significantly expanded. In a 20 years old female who is complaining of progressive loss of weakness, this large stir hyperintensity could be because of some demyelinating disorder because the cord is not expanded. I'm thinking in terms of could be neuromyelitis optica. I would like to see the
Look
so
here.
okay, so I'm provided with axial sections in which I can see that there is inverted V-shaped hyperintensity noted involving the posterior cord in the midline. In a 20 years old female, this inverted V-shaped hyperintensity, this makes me think of subacute combined degeneration of cord, which is because of vitamin B6 deficiency.
Yes.
Okay, and I would convey my finding to the referring physician, and this patient will need to be started with vitamin supplements. And in my routine practice, I would see the entire stack of images to look for any other demyelinating patch elsewhere in the brain.
What is the most
Yeah.
common predisposing factor for this disease?
So this is a vitamin B6 deficiency.
Okay,
I
it
think
is so
B12. Yes, sir.
B12. Yes, B12.
B12, sir. B12.
What
Yes,
is the
sir.
most common causes for this disease? Causes that
Uh,
cause vitamin B12 deficiency.
so dietary deficiency or sir some malabsorption, dietary
What
deficiencies.
else? What else in
Uh,
UK? You are going to work in UK. There are very common cause for UK.
so lack of, I think, sir, this is commonly found in green leafy vegetables. I mean, dietary cause could be a major thing.
Okay. What is the complaint of this patient? This
So
patient
so
came to you. If you examine this patient, he will have some neurological abnormality. Could you describe one or
so
two of them?
so basically, I think the patient will have this is a dorsal cord. So this is affecting the
Yes.
dorsal cord. So probably the
Okay.
pain sensation, I think, will be affected. I think I think the
Okay.
pain, touch, temperature. The patient will
Okay,
be
excellent. And proprioception.
yes, sir,
Thank you,
being
doctors.
touched. Thank you, sir.
Thank you so much. This is inverted V shape of the posterior column, which is pathognomonic of subacute combined degeneration of the cord. The most common causes is number one, alcoholism. Number two, sleeve operation. Okay, and malnutrition, malabsorption, whatever. But alcoholism, if we remember during our study for internal medicine, alcoholism is very, very common cause. Okay. Uh, Thank you so much. Look here, my
Thank you.
colleagues. Our colleague did very well when she asked for stair. Why? Because maybe this abnormality artifact. How can we confirm it in stair? So stair, sagittal and coronal is a must in MS. Any demyelinating disease, we in our protocol we should do coronal and sagittal stair for the brain. I mean the brain and sagittal for the cord. And to cover another axial and coronal stair image for the optic nerve. Very critical to rule out MS. Here, this is not MS, by the way, so we must we must examine all the sequence. This case, another lesson from this case. Why? What is the lesson? You must see all the sequences, or you must request from the examiner. Doctor, give me the axial at least. See, when we saw the axial, our diagnosis completely changed from MS to subacute combined degeneration. Next candidate.
Assalamu alaikum, sir.
Because, Doctor, this
So
is
could you please
10. Could you request control, please?
sir, could you please call
10,
for me?
yeah, 10-year-old male patient complain of left eyelid mass.
Okay, so I'm provided with MRI axial slices T2 weighted sequence, in which I can see there is soft tissue thickening in the left preseptal region, and it is extending. There is mild, it is extending posteriorly, involving the lateral wall of the orbit. It is heterogeneously hyper intense, and I can see there is mild proptosis as well. The brain parenchyma essentially appears normal. No abnormal signal intensity seen within the subcortical and deep white matter. So I would like to see other images like contrast or DWI.
The only available this one and
Sagittal.
this one.
Yes, sir. Okay, so these are sagittal images, sagittal T2 weighted images of the 10-year-old male patient who has left eyelid mass. I see that the globe appears normal, and there is preseptal thickening, that is also involving the eyelid. So I would like to see, sir, other sequences as well for further characterization of this lesion. So on post-contrast images, I can see that this lesion shows heterogeneous post-contrast enhancement.
What else?
So there is the prominence of the CSF spaces in the left temporal region. So I am also suspecting dysplasia of the sphenoid bone.
Okay. Could you have a look here? Here.
Yes, sir. Yes, sir. I can see that there is herniation of the. Yes, sir.
What else?
So there is a prominence of the CSF, extraaxial CSF spaces in the left frontal region, and I can also see a hyperintense area involving the left basal ganglia region that is also extending and involving the internal capsule, hyperintense area.
Yes. So,
Sir, other than that, sir, could you please scroll?
so what do you think?
So this could be a case of neurofibromatosis with abnormal high signals in the brain parenchyma, focal abnormal
Yes.
signals with the sphenoid wing dysplasia,
Okay.
through which I can see the formation of CSF and meninges through that into the
Yes.
orbit, resulting in proptosis
Yes.
and swelling in the preceptal region.
Mm-hmm.
Sir, I would like I will inform my finding to the reference physician, and I would like to know if any previous imaging available, and I would like to review the history of this patient, and would recommend CT as well, and would recommend whole of the neural spine MRI, neural axis MRI to rule out the possibilities of neurofibromas associated with the neurofibromatosis type 1.
Unfortunately, the mother of this kid complaining that he has chronic headache. And after measuring his BP, he has elevated blood pressure. Could you enumerate different causes of high BP for this patient?
Sir, in neurofibromatosis spectrum, there could be a pheochromocytoma in the adrenal region.
Yes.
That may be one of the cause of high blood. Other than that, sir, any vascular stenosis and vascular narrowing of main
Yes.
renal artery, that may be
Okay.
one of the reasons, renal artery stenosis.
Mhm. Yes, excellent. Uh, what is your next step for this patient?
Sir, I would like to see the neural axis MRI, complete neural axis MRI to rule out other diseases associated with to rule out the other manifestations of the disease process, like dural ectasia and lateral meningocele and vertebral anomalies, and rest of the spine needs to be screened. It's mandatory.
Yes. How could you describe the lesion of the eye? What is the nature of this lesion?
Sir, which lesion in the orbit?
In the orbit, yes.
So this could be, since this is a known, sir, this is a patient of neurofibroma. So this could be, sir, neurofibroma in this region.
Yes. What is the
Other
origin?
than that,
But this is
sir, this could be due.
not related to the optic nerves. So, what is the origin?
Yes, sir.
What is the origin of this
The
nerve?
other nerves that supply the eyelid,
Like,
sir, upper, sir, like, sir, ophthalmic branch of the, sir, V5, that supplies the skin and the upper portion of the eyelid. So
okay,
that may be the region of.
okay. Could you have a look here? You mentioned in the beginning this is a preceptal. What about
Yes.
this component? What about this
So this is
component? Mhm.
so this is so this is lateral orbital wall, but conal and intraconal space, I think it's normal. It is
So the
involving
lesion
the
is
lateral wall
only
of.
preceptor or intraorbital? Look
So
here.
it is preceptal, yes, sir. Extraconal and preceptal, yes, sir.
Yeah, see, preceptal is here. What about this one?
Yes, sir.
This one is intra-orbital extra cone. Okay?
Yes, sir.
Because
Intraorbital.
all of this, the lesion, look here. Look here, this is pre-contrast. Look. This is post-contrast. Compare.
Yes,
Look.
sir.
Look. There are extension here. Here. Okay?
Yes, sir.
Enhancement here.
Yes, sir.
Okay? Thank you,
Yes.
doctor, so much. Another lesson from this case, we must ask ourselves in each brain case especially, or abdomen, is this syndromic or not? especially when the patient is young. Okay, I give our colleague one very clear. There are left orbital mass, very clear. We must ask ourselves, do you think the examiner is so benign to this degree? No. So we must search for something else. This is not trauma. The patient has left eye mass, and this is the history from the beginning. Left eye, late mass. Okay. So there are something hidden. There are something more dangerous or more detailed than this mass. I must ask myself, what should I do? I should look exactly. When I found any something abnormal, I should describe well. You did very well when you describe this, but you told me, doctor, the brain parenchyma is normal. No, look at the basal ganglia. There are multiple phases, focal area of signal abnormality, signal intensity. It's very, look here also, very characteristic of NF1. Okay. Second, you must give the examiner the next step and management before he asking you. If we look here, I think my colleague, you will see it is very clear here. So, sphenoid wing dysplasia, very common, very, very common. Doctor, I want to ask you another question. What is the most common primary which metastasize to wing of slide? Do you know?
It's a neuroblastoma metastasis.
Okay, what else? What else?
Sir, could you please repeat the question?
What is the most known primary cancer which metastasizes to wing of snoid?
So neuroblastoma metastasis. Other than that, sir,
I think breast also. I think. Okay. In X-ray, there are very common signs to greater wing sphenoid dysplasia or agenesis. Oh,
yes, sir. The bare
could
orbits.
you, excellent, excellent. Thank you, doctor, so much. Next candidate.
Thank you, sir.
Good afternoon, sir.
Afternoon. I think my voice is clear, my colleague. Any doubt about or any concern about my voice, please comment or warning me.
The voice is clear, sir.
Yeah,
Okay.
thank you.
Okay, so
Thank you. Anything about the last case? It was sphenoid wing, greater wing dysplasia. Okay, what is the dysplasia? Part of it is not formed, defect. Even if you told the examiner there are a large defect in the greater wing of the sphenoid along the lateral wall of the orbital, this is highly suggestive of NF1. You would be correct. Okay. Okay. Any question? Another question I think about bare orbit sign. It is the X-ray sign of the greater wing dysplasia. Greater wing of the sphenoid dysplasia. Thank you, doctor. Next candidate, can you request control, please? 40-year-old female patient presented with postural headache worsening since 2 months. Yalla, go on.
So I've been presented with axial MRT1 post-contrast images of a 40 years old female patient who have been presented with headaches and postural hypotension. So here I can see that there is pachymeningeal enhancement, which is a continuous, smooth, and it is involving bilateral supratentorial region. And now I'm looking for the presence of any focal intraparenchymal area of enhancement or abnormality. I'm trying to look. So I was going through the images. So apart from this, I cannot find any. So I can see that there are dilatation of the superior sagittal sinus and sigmoid sinuses, and there is in my routine practice, I will also check the sagittal image to look for the presence of any transtentorial herniation or yeah. So here I can see that there is a decrease in the distance between the mammillary body and the pituitary gland with the uh, yeah. So there is no tonsillar herniation. The CSF spaces appear intact. So in summary, the findings are of intracranial hypotension. In my routine practice, I'll also check the subdural hygromas, which are associated with this condition. May I have any flare image, sir, please?
Flare. Flare. Okay. But what is your next step? Please explain.
So I will convey the finding to the referring physician, and this is intracranial hypotension. So I will convey the finding, and further management by the neurology team in this case is suggested.
But the neurology team didn't know the cause till now. You are the radiologist. And they
Okay,
asking
so
you, doctor, what is the cause? What is your next step?
okay. So I will examine the whole neural axis for presence of any CSF leak, which may be a cause of intracranial hypotension in this case. If the patient has any recent history of surgery, this may be due to that. So myelography initially was done for
So
diagnosis of this.
what is your next examination?
Cervical and thoracic spine imaging is suggested for further evaluation in this case. Okay, so I've been presented with axial T. So here I can see that there is increase in CSF space posteriorly. So I'm just looking, trying to look at the site if I can find any site of leakage or continuation. So there is an area of altered signal which is present posterior to the spinal cord. In my routine practice, I will also check the sagittal view to confirm my finding, because I can see that there is differential intensities are seen posterior to the cord. So on the provided fluid sensitive images, sagittal, I'm trying to look for the presence of that area which I saw on axial images. So I'm just going to check. So there is an area of hyperintense signal which is present along the distal or upper thoracic spine. Yeah, there is an area of high intensity signal which is present in the upper thoracic
Leave the
spine.
mouth,
My routine
please.
practice, I will.
Leave the mouth.
Okay.
Look here. Concentrate in these slides. What happened?
Okay. So there is extradural uh, um, high intensity signal which may represent a leak into this
Yes.
area at this
Where is the
site.
dura here?
Yeah.
Where is the dura? Show me the dura.
Can you see my
Indicate
cursor?
by the yes.
Yeah, this
Yes.
one. Yeah,
Okay.
this is the dura.
So, what's your final
So
diagnosis?
this is this is extradural collection, which is most likely CSF leakage site. So I will convey this finding to the referring physician, and further can be treated patient with the autologous blood patch. In this case, it may help to reduce this leakage.
Thank you, doctor, so much. My colleague from the beginning. This is what happened. Diffuse, smooth backmeningeal enhancement and distension of the sinuses and reduce the capacity or size of the ventricle. Okay. All of this,
Okay.
even the basal system, all of these are signs of hypotension. You did very well when you asked to rule out any collection, subdural correction. I think, the next step, number one, to ask the patient about any nasal discharge, okay, any previous trauma,
Okay.
surgery, even spinal surgery. If there are, all of these are negative, we should do, for example, the examiner, I will do CSF flow metering, for example, for the brain, or MRI whole spine to rule out any leakage. This is the ideal answer. When we did here, it is very confusing. Why I bring this case? Because it is very confusing, really. Our colleague in the beginning told us this is a prominent or dilatation of CSS. No, this is the dura, this is the core, and this is extradural CSF leakage. Look, look, look. This is the dura, this is the core. Look here after treatment. Look, this is the cord, this is the dura. The fluid inside, around the collar, but not outside the dura. Look here.
Okay.
The opposite. The dura is compressed by this extradural collection. It was a case of intracranial hypotension due to extradural spinal CSF leakage treated by blood patch. August blood patch, thank you, doctor, so much. It's very common
Thank
post-spinal anesthesia, post-spinal surgery, whatever, post post-motor car accident from fracture of skull base. Thank you, doctor, so much. Next candidate.
Thank you so much.
Yes, sir.
Uh, 2-year-old, can you request control, please? 2-year-old male patient
Sir, can you
complaining
scroll
of
for me, please?
yes. 2-year-old male patient complaining of headache.
Okay, I'm presented with the FLAIR axial images of a 2-year-old patient, and I would like to take a moment to see the findings. Okay, so I can see that there is a dilatation of the right lateral ventricle. Other than this, I can see that there is some flare high signal intensity, which is involving the right frontal subcortical white matter. Okay. So I can see that the occipital horn of the right lateral ventricle is dilated more as compared to the left side. And I can also see that, okay, I can see that the right cerebral hemisphere appears to be of larger size as compared to the left. So, so can I get the coronal images or axial T2?
Jesus, coronal
Okay.
T2.
Okay, so I can see that there is diffuse dilatation of the ventricular horns involving the frontal and occipital regions, and there is a a deviation of the septum pellucidum to the left side as well. I'm looking for any migrational abnormalities associated with it, or gray matter heterotropias. I cannot appreciate anything like that. I would like to think that this might be because of the enlargement of the one side of the cerebrum, but the dilatation of the right lateral ventricle is likely in keeping with a cortical atrophy on one side, and the other side appears normal. So this can be because of um, hemimegalencephaly, in which one part of the brain is enlarged. I would like to see
Concentrate
the, yes,
concentrate in this slice. The answer in this slice.
okay. Sir, okay, I can see that the
Okay, the left temporal lobe is normal. The right temporal lobe and the hippocampal area is slightly abnormal and asymmetrical. The third ventricle also appears slightly dilated. And other than this, sir, I cannot appreciate that there is any focal lesion. Um,
Okay. What else? See, you've got
okay.
the right lateral ventricle is markedly dilated. What would
Yes,
you think the cause?
sir.
Okay.
Sir, I can see that there is thinning of the right medial temporal lobe, medial cortex as well. So there is some
No,
kind of,
no.
yeah, okay,
The right hemisphere is not enlarged.
okay.
Look again. What happened here for these symptoms? There are enlargement here or dilatation here. And what happened here? What happened?
Sir, it appears to be thinned.
Okay.
Okay.
Look,
There is
look
thinning,
at this
yeah.
one. What is it?
Sir, foramen of Monroe?
Yes, foramen
Yes.
of Monroe at the left, showing this black CSF. Why the CSF is black here? What is the name of this phenomenon?
Sir, this is because of, uh, sir, in which there is, we say that there is a seepage or high pressure.
Yes, yes. Look here at the foramen of Monroe here. What happened for it? Here we can see flow through the foramen of Monroe. Here, what happened for the foramen, right-sided foramen of Monroe?
Sir, it appears to be blocked by a tiny septum.
Yes, so this is a case of,
Okay, so this may be because of the stenosis, aqueductal
yes,
stenosis. Okay.
stenosis. No, 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 not aqueductal. This is a foramen of
This
Monroe.
foramen Monroe, yes, sir.
Right, occlusion of the right-sided foramen of Monroe result in right-sided
Hydrocephalus, yes,
lateral,
sir.
yeah, lateral hydrocephalus. And what is this? This is the jet. When the CSF became under pressure, okay, it is looks like it has a very, very high velocity. So we can't detect its signal by the MRI, the normal MRI, conventional MRI. So the signal is black because this is jet. The enlarged right
Okay,
side ventricle compressed the left. So the pressure here uh, became under it. So it was a case of right foramen of Monroe obstruction. Okay,
okay. Thank you, sir.
it is a very rare case, by the way. For me, this is the first time I saw it. So don't worry, don't worry.
Okay, sir.
I'm trying my colleagues to bring all the scenarios. It is a case of a rare case. This scenario relate to rarity. The cases before each case has a different scenario. Okay, my colleagues. So
Yes,
take
sir.
care. And if the case is rare, try to use the logic. What happened for this one? Either atrophy here or obstruction. Look here. This is not atrophy. This is not megalencephaly. This is normal. And just this is enlarged. Go down. The other ventricles are all the other ventricles are normal. So the outlet of this right lateral ventricle must be obstructed. That is what we get here in T2. T2. Okay, if you bring the flare, you I see. Okay, look here. The foramen of Monroe here is open. Here restrict. Okay, my colleagues.
Okay, sir.
Thank you so much. Next candidate.
Hi, good afternoon, sir.
Afternoon. Uh,
Can you hear me?
yes, yes.
Okay, sir.
1 second. Mini question, orbital lesion, or plexiform. I think the orbital lesion was plexiform, neurofibromatosis. Yes. Diagnosis of last case. This is diagnosis. Foramen of Monroe obstruction, unilateral, right side. Okay. Thank you so much. Doctor, this patient.
Okay, so can I request a remote control?
Yes.
Uh,
35-year-old
okay.
male patient presented with headache and convulsion. Uh, for 3 months. Request control, please. Go on.
Okay. Okay, so the history was a 35-year-old female uh, with history of headaches. Sorry, I couldn't. Headaches and convulsions. Yeah. Okay, so this is I'm provided with axial T2 weighted MR of the brain of an adult patient. I'm just scrolling once to have a look and then we'll describe findings. Okay, the most striking finding I can appreciate on this axial T2 weighted image is a large hyper intense lesion in the involving the right thalamus, uh, and it is causing significant mass effect with compression of the third ventricle. Um, as I go down, sorry, it's going up. Okay, sorry. I don't know when to go down and when to go up. Sorry, sorry. Um, it is going. It's going up. Now it's going down. Okay. It is extending downward into the. Yes, it is extending downward and it's also causing a mass effect on the posterior aspect of the right half of the midbrain as well as the aqueductal lesion. And again, showing some areas of low signal intensity in the periphery as well. Okay, the
Do you need any
bones, cerebellum and
other
posterior.
sequences?
Yeah,
Do you
I would
need
like
any
to
other
look
sequence?
at the post contrast images, flare and post contrast, if I can.
Look here first.
Okay, this is these are the sagittal retroverted MR images. Um, mm, sorry. Oh, it is stuck. Okay, I can't see the okay, there is extensive extension of this hyper intense mass, which I can see. It is mm, it is lying in the posterior to the midbrain, and I cannot appreciate tectal plates, or there is this inferior displacement of the colliculi, and also I can see the extension of this mass anterior to the midbrain and the pre what we call
The post contrast. This is a post contrast that you asked before.
yeah.
Mm-hmm.
Is this post contrast?
Yes, sure, sure.
Okay.
Please
Okay,
advise.
okay. This is post-contrast scan, and this is on this post-contrast image, the lesion is hypo-intense, and this is not showing any contrast enhancement due to the insinuating appearance of the mass. I'm suspecting some cystic lesion, and
Yes,
I would like to look at the different DWI image to confirm my finding, because the differential for the uh, yeah, it is this lesion is hyper intense on DWI, and it is hypo intense
what's
on
your diagnosis?
ADC. So the different restriction is positive. So I think my differential would include epidermoid cyst as the top differential, with
Yes,
the second possibility of arachnoid, which is less likely because we do not see different restriction in the arachnoid cyst.
but the
Um,
oncology consultant is highly suspecting the tumor, so we refer the patient or we made a complementary MRS. What do you think about this MRS?
okay, on the MRS, uh, this is I'm just looking. It is showing a high peak, NA peak. I'm looking for any choline peak is quite low. Um, so I
Hmm?
think it doesn't favor the doesn't favor any tumor in this case. There is also lactate. Uh,
Is this normal or abnormal?
yes. mm, I think for this voxel, there are multiple peaks of Na and choline. I'm just looking at,
Normal
but
or
in any
abnormal?
case,
Normal or abnormal?
mm, mm,
Where is the NA?
normal, normal. I think
Where is the choline? Normal or
choline is
abnormal?
there, but it's less than choline is there, but it's less than Na, and
It is normal or abnormal? This is choline. This is
that's
NAA.
such. I haven't seen such a. This is Na. Yeah. And it's showing the
Mhm.
normal neuronal parenchyma, I think,
What's
yeah.
your final diagnosis?
In case
Your final diagnosis.
uh, it's an epidermoid, I guess, due to the
It is,
insinuating nature, the morphology, and on keeping in view the DW and ADC finding.
thank you, doctor, so
MRS
much.
is quite confusing. Yes,
Thank, no
thank you.
problem. Thank you so much. Look here. Look here. What is this? It is a midline large signal abnormality. At least we don't know is this cystic, solid. We don't know. Also, it
Yeah.
is posterior to post-Salomon, inclined to more to the right. Next step, ask
Mm,
for sagittal. Because why? It is a pioneer region lesion. When we saw the other plane, the location completely changed from you described something interaxial. You told me it is centered on the posterior aspect of thalamus. No, see, it is extra-axial.
mm,
It is insinuated here, centered at the pioneer region. Next, you ask for contrast, non-enhanced, not hypo-intense. Restricted, so it is a restricted cyst. When I give you, so most probably epidermal. When I give you this one, this is at least non-tumor. At least why? Look at the choline and NAA. NAA, N-acetyl aspartate, is the normal neurotransmitter. It must be high here.
yeah.
This is the normal level. The choline is the cell wall phospholipid, as I say. When the number of cells increased, like in tumors, the choline became very high here. And this is abnormal cell, so the Na become very low. NAA, you can see it about 2. Here, this is the normal location. Choline 3.2. Okay, this is the normal location. Here, I think point 0.9 here, about here. You can see the lipid and the lactate peaks, and it is inverted. For example, if you have cystic changes in a tumor, you will see a very negative curve coming down here of lipid and lactate, or in case of abscess. This is the most common 3 component you must concentrate. Here about 1 or 0.9, here, exactly here. The lipid and the lactate inverted peak. 2 is Na, 3 or 3.2 the choline. This is the most important. And the choline, if you take a ratio between choline and the create, it must be abnormal. It must be abnormal because the create is the normal metabolite of the normal cell. When the choline in tumors, the choline is very high. Okay, so when you divide the choline by the create and get the ratio, I think this is some ratio here, some ratios. It must be more than 1, more than 1 by many times. At least you keep 1 lipid lactate, 2 NAA, 3 choline. Thank you, doctor, so much. Last case of today, very important case. Last candidate. Hello?
Dr. Rami, we had 6 candidates only. So
6 candidates
if you
only?
want, yes, yes.
Did you take your role, Dr. Amiga?
Yes, sir, I have taken. If you want, I can take this. If no one volunteers, I can take this.
No, anyone, the next candidate from the list, anyone like to share? Hello?
Let me check.
Anyone?
So for today, the list is over. We can ask if anyone volunteers. So we had 6 candidates only, so that is yes, someone volunteers. Mujahid Raza.
Yes. Yes, Dr. Mushahid Raja. Open the mic, please. Alaikum salam.
Assalamualaikum.
Doctor, this is, by the way, it is a case of discussion.
You can hear me?
Yeah.
You
Can you hear me? Yeah, I hear you.
This is the
Doctor, this is,
control.
yeah.
I
Ask him
request remote control.
Yes. 35-year-old female patient presented with headache. Ask for control. Okay, I
Yes,
will
I
control
requested.
for you. No request sent for me.
I requested. This is the MRI brain T2 exhalated images with 5-year boy, history of headache.
Yes.
There is a fourth ventricle is dilated, cerebellar folio are dilated, and this is list of cerebellar atrophy. There is area of altered MR signal is also seen in the brainstem,
Yes.
especially in the this medulla oblongata. So there's
Yes.
list of pontine myelinolysis. Rest of
But the
the
patient, see, but the patient has a history of headache only. Examine first all the available sequence, and after that, give 1 or 2 logic provisional diagnosis.
No, I want to see the T1 X image.
See,
T1
this is a
images.
flare. See, this is a flare.
Okay.
What happened?
On the flare images, I can see the ventricular chain appears normal. There is a governor sinus appear normal. Okay, I recognize normal. I could not see any space occupying lesion. The orbits are gross normal. So this appears to be unremarkable for me.
Okay, this is the diffusion. What happened in the diffusion?
On the diffusion weighted images, I can see the Could you please console? Can you scroll? Can you please scroll it?
Yes,
Can you
yes, I
please
will
scroll
scroll.
it?
Yes, what happened here?
On these definitive images, I can see there is the low signal area is noted, small low signal, the posterior aspect of the brainstem, which was relatively high signal on T2-beta images.
Yes,
Rest,
what else?
rest.
Is this restricted or no? The lesion, this lesion, this is the DWI. Is this restriction or not?
No, this is not restricted
Okay, look
because
here.
it's not signal.
What happened here? What is the name of this sequence?
This is, I think, T2 XL images. On the T2 XL images, it appears low signal.
Okay,
So,
but look here. Look here. This is T2.
this could be susceptible. No, this is not susceptible. This could be
Okay,
proton density.
susceptibility. Okay, what happened here?
It appears to be low signal. This, I think, this is something related to cavernoma or some hemorrhage.
Okay, but look here in the post contrast. What happened? Enhanced or not?
Post contrast, it reveals enhancement. So this could be
Is
cavernoma.
can cavernoma enhance it?
Yes, it can. Cavernoma can enhance.
Very rare. No, very rare. Look at the pattern of enhancement. Look.
Pattern enhancement is patchy. Not typical of this nodal enhancement. Second, this could be some infarct which reveals patchy enhancement.
Okay, but they are worried about being a mass lesion, so they did MRS. Look here.
MS
Look
choline
here.
peak has increased. So that
Okay,
is
but
just
could you think this is the usual choline peak in gliomas?
no, this is not
If
usual
you,
glioma. Glioma, this is highly up.
blue 0.01. Okay, look here again. The pattern of enhancement is very characteristic for something. C, signal abnormality that cause blooming artifact here. Okay,
Yeah.
blooming artifact and enhance it here. Okay, but not restricted. It has two different criteria. Enhanced but not restricted. MRS is not of the glioma, but it has a blooming artifact. Look here.
Yeah.
Look here. What is this?
This could be some cerebritis.
No, cerebritis will not enhance like this homogeneously.
Could be some sort of the cavernoma.
Yes. Cavernoma will not enhance like this. What else?
Could be some
You are very near, by the way.
Some infected disorder. Just
The patient
like
has no fever.
Tuberculomas, the patient has no fever.
Tuberculoma will not have this high T2 inside. Tuberculoma has low T2. What else?
But by polyton myelinolysis, extrapolyton myelinolysis.
The patient has no history of ICU admission or alcohol or malnutrition. The key is this one, gradient. Why this cause? See, why this cause blooming artifact? Because this contains iron, but not cavernoma. What is the name of lesion which has blooming artifact? It has bent brushing or brushing enhancement, and finally it is not a glioma.
Some sort of AVM.
No, you are very near, by the way. Pontine capillary telangiectasia. Really, doctor, thank you. You make a very great discussion. And this is some cases, the examiner may bring one case for open discussion. He wanted to know what is in your mind. Case like this very difficult, and the most important, he wanted to know what is your differential diagnosis. Are you talking haphazardly or scientifically? I think you did this one. You were talking about something vascular around both ICA. Okay. So it was a telangiectasia. Both ICA were normal. My colleague, somebody asking, this is normal. Okay, this is normal. Both ICA. Look here. This is ICA normal, and the other one also normal. The abnormality is this one. Telangiectasia, capillary telangiectasia. How we diagnose it? Blooming artifact in the whole lesion. Next, it is enhanced, so it is not cavernoma. Okay, not cavernoma. Cavernoma will not enhance like this. So when you see criteria of cavernoma ingredient, but enhancement, and enhancement like brush, the brush streets. Okay, and if you look here in the middle, there are draining vein. This one. So it is the criteria of capillary. This is the answer. Capillary, pontine capillary telangiectasia. Thank you, doctor, for so much for all of you for your participation. Each case of today express a different scenario of the exam. Hopefully, we will meet next Thursday. Keep study, keep motivated. You can do it, all of you. Thank you.